Today, we're talking about autism, and we're going to talk about autism across the age groups in children, adolescents, and adults. And with me, I've got an expert on the topic, my colleague and my teacher, Dr. Tim Morris, a consultant child psychiatrist. Hi, Tim.
Hi, Jack.
Thank
Good
you for
morning.
joining me today.
Welcome.
So, to set the agenda, we're talking about autism, what it looks like for all the age groups, and we're going to try to talk a little bit about how we assess it. And we're also going to talk about the controversial topic of why it's a disorder and what does neurodiversity mean. And let's go. Let's get straight to it. What is autism?
So, autism's big in the news, big on the internet. There's been an explosion, if you like, of people exploring autism and autism diagnosis, probably over the last 10, 15 years, with the emergence of something called autism spectrum disorders.
The magic change.
Yeah. So autism is a social communication difficulty or a disorder. And that's where you may have no communication, so no speech, no language, or you may have what appears to be reasonable speech and language, but don't understand how to use it in a social setting. So you get things wrong. And I guess that's the two edges of a spectrum, isn't it? No language, possible learning difficulties, to reasonable language, but just not quite getting it in a social setting.
So that's what we mean when we say spectrum.
Yeah.
From very, very deprived, very very affected social communication to social communication that's on the awkward side.
Yeah. So that's, if you like, part one of two parts of autism. The second part is rigidity, lack of flexibility, which at one level can be counting and repeating things over and over and over. You know, a little child that watches the same video 200 times a day and can't change, to at the other end, a preference for sameness, a difficulty moving from one activity to another because it stresses you. So there's two components to autism. The primary one, if you like, that people notice is the social communication difficulty, but you have to have the rigidity as well.
So we're kind of looking at a person's ability to converse with the world, with people in it, and with events and surroundings and environment. And when we look at how a person converses with people in the world, we split it up. So when we say social communication, that's kind of our way of saying how a person converses with other human beings. And that can have a verbal form, how we communicate with language, understand language, as in receive it, and also use it. And the other bit is the nonverbal bit, which is how we understand and express emotions in using our body language, using our gestures, using our facial expressions, but also how we understand other people's body language and facial expressions. And then there is the bit of how we deal with people and their unspoken rules. So social communication also includes the social rules. For example, how it's important to respect people's distance. Distance is a big thing, and that's one of the things that we understand. For example, where I'm from in the Middle East, personal distance is viewed socially as very small. It's okay to kind of queue up very close to each other. Here in the UK, the rules are different. You have to have a very distant personal space where you have to queue about an arm's length apart. And these are the unspoken rules that we have to understand when we're dealing with other people in the world. So that's what we mean when we say social communication. And then there is the conversing with the environment and with the rules of the world, how we make sense of it. That's the repetitiveness, the inflexibility, the attachment to routines.
Yep, yep. We try to neatly divide those two components, but of course, in real people, they're not. It's never so neat. And now we're talking about a spectrum. There's huge variation. So there's huge variation culturally anyway. For example, as you said, in different cultures, there's a different level of closeness. But there's also unwritten rules. So you may be physically closer to people in your family, to people who are close friends. There may be hidden rules about, touching people. If you haven't seen them for a long time, you may give them a big hug, but if you've seen them, yesterday, you wouldn't. And it's really complicated. And people with autism struggle with these sort of things because it's not written down, it's not structured. You have to work it out. And then, so they're the core features. They're of course different at different ages. So very little ones, we'd probably say the under fives, may have more difficulty with eye contact. Just going back, people with, if you like, severe autism that fell under the old categorization of childhood autism. So pre-2015, we had different labels for them that people will have heard about. Childhood autism, Asperger's, the other sort of.
Childhood autism and Asperger's are still being used among some clinicians and some and people as well as terminology, because we've moved on from that since 2015.
Yeah, if you had a previous diagnosis of childhood autism or Asperger's, you would now just be called autism spectrum disorder. That's the convention rather than retesting. So there's a group of people who would fit the old diagnostic criteria of childhood autism. They tend to be, if you like, more autistic, so have more autism features. People with historical diagnosis of Asperger's, or sometimes called high-functioning autism, had less features. But they're all now encompassed within this spectrum. And then you've got your age dimension and what's obvious in the under fives. So you may get a group of people who have more obvious autism spectrum disorder under 5. And there's be a group of people in the under 5s where we don't think they've got autism, but when they're 5 to 10, you start to think about it because the symptoms become more apparent. Or again, in the teenage years, and teenage years is the biggest pickup for cases that haven't been seen before.
Why is that?
And coming back to the social world, the social world is the most complex when you're a teenager. One, you're learning the social world. 2, it's very pressured, and you're, in a way, with our school education system, you're forced into a certain social pattern wherever in the world you are. Once you're an adult, you get a bit more choice, so you can kind of find your space in the world. So there's sort of probably there's the under 5s, which are perhaps a different group in terms of doctors and clinics spotting it. Often that group hasn't started with spontaneous language by, say, 2 years, and people start to think, oh.
So we're gonna group it up and talk about it under 5s, and then between 5 and let's say 10, and then from 10 to 18, and then 18 onwards. So let's talk about the under 5s, because that's a very common, and I get people asking people I know socially, people asking me this question, well, my child is 4 and I think he's a bit awkward. He's the language is a bit delayed, and it's just, and they have a brother who's autistic, I think. And how do we draw the line? Let's talk about this and try and explain it to people. How do we draw the line before the age of 5? Because that's a child who's potentially still developing. We don't know where they're going to go.
Yeah, I mean, I think what you just said is the important one for parents to hold on to. Is quite often we don't know.
Hmm.
So in some cases we can make a diagnosis, usually with no language or very limited language, very rigid patterns of behaviour. Yes, you can make a diagnosis,
Hmm.
but quite often you can't, and that's frustrating for families and parents. But it's probably better for the professionals involved to say we're not sure,
Hmm.
we'll wait, than it is to either say no, it's definitely not autism when it might well be, or
Hmm.
yes, it is when it might not. And that is definitely the hardest message to convey. We're not sure. That your audience will know about nice guidance. Nice guidance. There's nice guidance for assessment and recognition for autism. Nice guidance says you might have to wait a year.
Hmm.
Come back to this in a year.
Yeah.
So if I was a parent, I would try and be happier with somebody who says, I'm not really sure, come back in a year, than somebody who says, oh, I definitely know.
So the not knowing is very difficult, I think, for parents, and especially
Yeah.
at that age when you're making decisions about school and making decisions about what you're going to do for this child to help them settle into first year of school. It's a critical time. And I think what you're saying is that a lot of the time we just monitor. If we see, so sometimes we make a diagnosis if things are very clear, and often that means children who are nonverbal, who do not have the ability to speak or understand spoken language, or if the symptoms of rigidity are very, very clear and we can't not make a diagnosis. But sometimes if it's on the fence, we leave it on the fence. And why is that? What is the value of not giving a diagnosis or giving a diagnosis of autism very early in life then, do you think, Tim?
So there are probably two main things. The first is it might be something else.
Hmm.
You might need more investigations, more assessment of other things, other genetic disorders, simple things like hearing problems can present in that way. Some children who are very deprived can present in that way. So there are, one reason is it might be other things.
Hmm.
So you don't want to miss other things. And I suppose the other reason for delaying is there isn't a specific treatment for autism. Whatever the underlying cause of autism is, there isn't a specific treatment. So you're going to treat, often with educational interventions, with what the child has, irrespective of the label. So you should, if the child needs speech and language therapy, they should have speech and language therapy. Whether it's autism, there are some other labels. Semantic pragmatic disorder, for example, is a label where there isn't the rigidity. So whatever the label, the intervention should be carried out for the problem, not for the diagnosis.
That's very critical, isn't it? And that's often the hardest bit to try and explain to people who are new to the profession, or to explain to parents sometimes, is that we have, and in a previous episode we'd spoken about diagnosis and formulation, and that there is a part that you put a label on the thing, on the illness, on the presentation, but also you have to address the child, not the diagnosis, address the issues that are presenting, not the diagnosis. So that's very important. And like you said, it's important not to miss things that might look like autism. Let's talk about I just want to tip the hat a little bit to learning disabilities and other difficulties that can present with kind of red herring symptoms, and people might rush to the diagnosis of autism. What do we think about in the under fives? What do we look for other than hearing problems, vision problems? What do we think about in the under fives before we go to autism?
So, learning difficulties is the commonest issue. It is difficult because it's not usually instead of autism, it's often together.
Yeah.
And children, we group children by year age, certainly in the UK. And of course, there's a big difference. If you're a year younger, you're developmentally younger. People don't develop at the same speed anyway. So you can be within the normal range, but 2 years behind somebody who's in your age group, your pram group or whatever, because you're developing late. Very premature babies, for example, may develop late. Children who have a significant illness in the early period may develop late. So there's lots of reasons for differences in developmental speed. So that's one of the problems. You just don't know. You don't know whether this young person in, say, in a clinic setting is somebody who's developing on a slower but normal, we call about the trajectory, sort of development as a trajectory. And of course, I'm describing it like it's in a straight line, but of course it isn't. It's
a zigzag.
You may develop speech and language quickly, or you may develop it slowly. You may walk early. You may catch a ball. It's not straightforward at an individual level. If you group 1,000 children together, yes, it looks like that. The difference between somebody developing at one speed and another speed when you're 2 or 3 is very little. That difference can become greater as you get older, which is why you sometimes find there's a pickup in the 5-year-olds.
And parents will refer to this as a spurt.
Yeah.
Kids develop and flourish. The first year of proper school will look very different compared to kids who've just been in kindergarten or in nursery. So you think about, and I'm going to try and explain this bit about how we look at autism and learning disabilities or learning difficulties, right? So for the purposes of this, we're going to call learning disabilities, the intellectual disabilities, is where there is a global delay in the child's development. The child in every aspect of their development is behind where they should be with a critical degree. So it's not just within a variation, there's a critical delay. And what is the difference between that and autism? So autism is a delay in social communication and the ability to be flexible and converse with the world and the environment in a flexible manner. And if this delay in these two aspects is happening alone without other bits of this child's development being affected, then it's called autism. If it is happening as part of a global delay in the child's development, then it's within learning disability. If it's happening to a larger degree, so let's say a child has a learning difficulty, right? A learning disability, they're disabled intellectually. Let's say they have a general full-scale IQ of 70, right? But their social communication ability, their ability to converse flexibly with the world is delayed. Let's give it just an arbitrary score of 50. So there's a 20 arbitrary point delay between their social communication and flexibility and their full-scale development. So this is when we make a diagnosis of autism on top of a learning disability. So what I'm trying to say to people is that when we say we're thinking about learning disability as a differential, as a possibility when we're assessing for autism, this is not ignoring the social communication difficulties. This is taking them within context. And then there is also gender that we think about, because, and we're going to come to that in a minute when we talk about 10-year-olds and teenagers, but that's part of what we think about. And we think about environments. So children who grow up in stimulating environments develop differently to children who grow up in understimulated environments or deprived or neglected environments or abusive environments. So these also affect a person's development. But again, we think about the critical threshold, don't we?
Yeah, I think the learning difficulties is tricky to explain in that way, especially in the very young,
Yeah.
because they won't be expected to have developed high-level cognitive skills. Those develop in later teenage years. The measurement of IQ, you use the word 70 and 50, is imperfect.
Especially for that age group, isn't it?
Especially for that age group. Again, we've got the developmental trajectory. What you might be looking for is things like, even in your 4 or 5-year-olds, a parent who says, well, they're really good at this, this, and this. They remember everything about such and such Thomas the Tank Engine or whatever TV program they're watching. They remember every single episode. They know what's coming next, yet they don't seem to get it. So that's how you might see a gap between their overall, if you like, ability to function and their social communication. So you're probably looking more in that way than a technical test and measure kind of way. We've gone to the same supermarket every time and they get lost completely, or they wander off and they're just fascinated by tins of beans. So you're looking for things like that more than the technical testing. And I think one of the guidelines for clinicians is, if the parent thinks there's something wrong, take that seriously, because the parent usually knows. They might not know what the diagnosis is or what the label is, or they might say, oh, I think it's autism, when it isn't, but it's something else. But they're spotting something. And the professional's job is to try and work out what that something is. I guess from a parent's point of view, don't get too hooked into one particular diagnostic label that you've seen on YouTube or on a video, because most professionals would say, yes, you're picking up on something. We're not quite sure what it is. We'll try and work it out. And there isn't, I suppose this comes across all the age ranges. There are some good ways of assessing for autism, but there are no tests for autism. There's nothing that says definitely yes, definitely no. And sometimes people chase the test, and sometimes you just have to give it a bit of time. But listen to the parent or the carer, and also the school, because they're the other group of people. This might be preschool, but once a young person starts in school, they're the other group of people who, one, spend a lot of time with that child, and two, spend a lot of time with children. So they're generally good.
They have a sense.
They have a sense. Oh, they might not know what, but they know, oh, this isn't quite right. So I do that rather than testing for numbers, if you like.
Yeah. So the gold standard for us when we test is the ADOS, which is the Autism Diagnostic Observation Schedule.
Actually, the gold standard is ADI and ADOS.
Both of them, yeah.
Both of them together. So the ADI is Autism Diagnostic Interview, has been revised, and the ADOS 2, because that's also been revised. So
And
then,
the ADI, let's tell people what the ADI does and what the ADOS does.
okay, so these are technical instruments. There are others available. The ADIR is a structured interview asking about development.
Mm-hmm.
It usually asks in 3 age bands, essentially. One is what was the child like as an infant. They usually then ask quite a lot of questions about age 4 to 5. So you would typically ask a parent of an older child, what were they like at 4 or 5, which in the UK is usually, what were they like when they started school or their first year at school. So you can try and tag your memories to that period. And then the third bit is, what are they like now? But quite a lot of the ADI is tagged to the 4 or 5 year age group. And it's things like, did they make conversation? Did they understand conversation? Did they smile? Did they make eye contact? Did they point? They point to ask for things, or do they point for naming of things? What were their friendship groups like? Parties? What were their behaviour at parties? So it's questions like that. They're asked in a structured way. It's quite a long interview. It can take 3 hours. And then there's a scoring algorithm. You score in the different boxes and you come up with a number. Its main use is it helps you focus on a critical period in development. So for clinical use, it's just really good for gaining information. It's also used for research, which, given that we don't know everything about autism already, is also an important component.
Yeah. So some clinicians will use the ADI, and some will just take in your developmental history, which is a kind of a very similar form of asking questions about the development of the child, but without the scoring aspect of it.
Yeah.
And then ADOS, because people will have heard this term a lot.
So ADOS, Autism Diagnostic Observational Schedule, now version 2, has 4 modules depending on your language and age. Module 1 for little ones, has lots of toys. Module 2, intermediate, as is module 3, and module 4 is sort of adult or full language teenagers. So they're slightly different, but it is designed to do all ages.
Yeah.
It's a structured interaction with a child. So there's some games to play, moving shapes, playing with a toy. There's some questions to answer at the older age group, and there's some tasks to do. Pretending to wash your teeth. The idea is that for every young person, you ask them to do the same things. And it's a staged social interaction. Okay, so it's what happens in the interaction that's really the important bit, rather than the actual test. For example, some of the interaction is about making eye contact and responding to the examiner. So the examiner might ask a question, a young person might respond to it. Oh, that's interesting. Or they might just ignore the examiner completely. There's also periods in the ADOS where the examiner doesn't try and interact with the young person, and you see what happens. Does the young person try then to interact with the examiner, or do they just carry on? So it's really a staged interaction.
And it's a snapshot as well. It just looks just at this hour of interaction within this standardized tests or standardized tasks.
Yeah. It's very good. It's helpful. It's useful to compare that young person with other young people. So it's standardized. If the person doing the exam does it properly, it should be reproducible. So it should be the same wherever you go. But there's a lot of variability in how it's done. Again, it can be used clinically. This is what we found, and it can be used for research. Two different purposes. The big problem with it is people believe it. So, there's a score. Okay, that score means yes or no, and that's not true because it's a snapshot. It's also much better at picking up the social communication aspect and less good at picking up the rigidity.
Mm.
So you might miss things. And the third bit is there might be other reasons for scoring on an ADOS. For example, if you're depressed, you'll score in the autism range.
And that is very critical, I think, for the age groups of above 5 to 10,
Yeah,
and then 10 to 18. That's really critical, is choosing the time to
yeah,
make an autism assessment, because most of the time kids present to us, don't they, in those two age groups particularly. Some of them will come with the just main complaint of I'd like an autism assessment, but a lot of them will come with other problems, and autism will be detected as part of the rest of the assessment.
yeah. I suppose the other bit which we haven't talked about is at the moment we're conceptualizing this, if you like, as a deficit model. This
Mm.
is a group of people who have problems with X, Y, and Z.
Mm.
And of course, the other part of an assessment should be, well, what are their strengths? What are they good at?
Mm.
Etc. The ADOS can be quite good for that because it has lots of sections and it can show
Strengths as well.
strengths or
Yeah.
areas that aren't weak at all, even if you do end up with a diagnosis. And there is a danger with using these structured assessments that we use a deficit model because they come from a sort of, if you like, a medical or a psychological background that's looking for a problem. Have you got, so that's the other problem with the assessment, that the focus is on the deficit to make the diagnosis rather than the strengths. And of course, that can be quite important when you come to treatment because, yes, you're trying to make up somebody's deficit, but you might do that by building on their strengths. If you don't know what their strengths are,
Mm.
you know. I suppose the other thing is that diagnosis, even with gold standard measures, isn't perfect. So, if you get 70-80% correct, 4 out of 5 people, that's considered a really good kind of result for a gold standard assessment. But that does mean 1 in 5 you've got it wrong.
Mm.
It might be something else, it might not be anything. So as a family, that's quite. If it was me as a family, I'm thinking, well, 1 in 5, they get it wrong.
Mm.
Nevertheless, that's a really good measure for something that there isn't a test for. The
Yeah.
other thing is that somebody may fit the criteria at one age and not fit it at a later age. 9 out of 10 people continue with the same diagnostic label, but that's still 1 in 10.
We call that diagnostic stability. Is the ability of a person, is the ability of the diagnostician, the person who's making the diagnosis, to make a diagnosis at one point, and then this patient is reassessed in, let's say, 10 years, and it still applies. So I mean, there's going to be a day. There's going to be a day where we're going to talk about this because it's really important, and especially for autism um, and borderline personality disorder being diagnosed very early in life. Diagnostic stability is very critical. But like you were saying, there are so many things to take into consideration when we're making a diagnosis, and that's why you made a reference to the NICE guidance, which is our guidance here, and I talked about this in the episode about diagnosis and formulation of guidance.
Yeah.
And the guidance in the UK is called NICE, not because it's nice, but it's short for
Yeah.
something.
Guidance in England and Wales,
Yes. Oh,
not UK.
okay. Not Ireland then. Okay.
And Scotland has its own guidance called sign guidance,
Oh, it
which is
does.
very good. Which is
I
very
didn't
good.
know that.
Yeah.
Oh, that's good. Um, so what I was trying to say is that we make an assessment taking into consideration the history, the current presentation, the presence or absence of other problems or things that might affect the presentation that we're looking at. And then we think about also ADOS is one of the things that we use, ADI is one of the things that we use. Sometimes we need to do a whole cognitive assessment, which is looking at IQ or other parts. Sometimes we also look at ADHD as a possibility or something in the background. Sometimes if there is ADHD symptoms, then we make a decision to treat that first, or if there are depressive symptoms, we make a decision to treat that first and then reassess for autistic symptoms. But let's talk about the complexities. So we've talked about under 5, we've talked about assessing, and we touched a little bit on assessing the 5 to 10 age group, which is looking very heavily at school and performance at school. And also because this age group presents with a lot of other problems, we take those into consideration. And we also take into consideration the stability of this diagnosis. So what are the strengths of this young person or of this child, and what are the chances they're going to develop and make up for it? And you made reference to that diverging trajectory of development between a child who's neurotypical or is developing typically, and then a child who has autistic spectrum condition, and they develop, and as they age, then it becomes clearer and clearer that they're a bit different than their peers. Let's talk about teens.
Okay. So most people with an autism spectrum disorder it should be possible to make a diagnosis before they enter secondary school. Okay? Sometimes it's not done, but that's often because of, if you like, system problems, lack of hospital appointments, lack of referral pathways, rather than not being able to assess the child, if you like, the under 10. So most cases, 90% of people, it should be possible to make a diagnosis in the under 10s or the under 11s if we use the UK school year. So there's potentially two groups in the teenage years. There's the group that's been missed, where it would have been possible to make a diagnosis had they been seen, had they been assessed. So for that group, you're often doing the same kind of assessment just later, accepting that they're older in development, but you can do essentially the same kind of development. History, observation, examination, information from parent and another source and other groups. But essentially, if you'd seen them sooner, you probably could have made a diagnosis. You might not have been able to do it at 3, but you could have done it later. So they're following an autism pathway. It's just not been. There's then a second group, if you like, where they did not appear to have autism spectrum disorder when they were little, but now that the world has changed for them, they're appearing as if they've got autism.
Under the demands that have developed, yeah.
And that's probably because our criteria and our way of understanding was gender specific.
What is with the whole gender thing, especially in teens and adults? Let's talk about the truth of this. Is there a bias against females in autism assessments? Are we picking up boys better than we're picking up girls?
I don't know whether that's a bias against girls or a bias against
Four?
boys. Yeah, for girls. Because boys get diagnosed more.
Yeah.
So if you take it as a disorder, that would be a bias against boys.
If it's a diversity, then because that's our next thing,
Yeah.
is it?
So there's this group of, if you like, newly apparent people with autism spectrum disorders in adolescence. In terms of referral to our service, we do get more girls referred at that age, possibly because the boys have already had a diagnosis, because they more match the conventional criteria. So we've got this group of adolescents, often girls, but not exclusively, boys as well, who did not appear to have autism as a younger child. So they may have pretty good eye contact. They may have had pretty good social communication at a limited level. And yet they reach the early adulthood, adolescence, and they start to struggle in friendship groups. It is a much more complex time to diagnose because there's lots of other comorbid reasons. We talked about depression already. You could have anxiety, both general anxiety or even a social anxiety disorder.
Even the normal transitional crisis of being a teenager and a teenage girl, with the different demands that are on girls at that age compared to boys. And I think that we do take into consideration often the ability to, we call it, I'm trying to think of the word. Is it social mimicry or social mirroring that girls are really good at, apparently. And we see that anecdotally, and there is some evidence about it, not, but we do take it into consideration when we're making assessments. And I think that there are some societal pressures as well that are on boys and girls at that critical age to different degrees and at different ages and with different demands. So I think we do take gender into consideration when we make these assessments.
And there's something called masking, where somebody in theory has a underlying autism but picks up on the social cues using perhaps a different part of their brain, and they're able to mask. And that's an interesting one in the sense of that's what you're trying to teach people to do, isn't it? You're trying to teach them to understand the world. The gender, there's a convention to split the genders and say, well, girls are more social and just much better at this than boys, and boys are rubbish at it. And of course, I think it's probably fair to say that the very best girls are really good at it, and the very worst boys are really bad at it. I'm holding up my hands. But
so again, it's a curve.
Yeah, it's a curve, but the overlap of the curve is much greater than the separation.
Yeah.
You can't. It's nice to go, oh, yes, the girls are in one camp and the boys are in the other, but that's just not true. There's lots of boys that are really good socially.
Yeah.
And there's lots of girls that are not that good socially.
Yeah.
So it's more a way we talk about it, if you like, in the media than in reality. In the same way, if you think about height, yes, girls are generally a bit smaller in height than boys, but there are plenty of tall girls and there are plenty of small boys. The tallest tend to be boys and the smallest tend to be girls, but there's a huge overlap.
Yeah.
And height's a good example because, of course, height develops at different speeds in different people, and there is a sense that girls develop a little bit quicker than boys. So if you use that as an example, that's happening socially. The other component that one has to bear in mind, taking out gender, is cognitive development goes through stages. We're a little bit unclear what they are, but there is something called concrete operations where we kind of think in black and white, and there's something called formal operations where we extrapolate. Concrete operations, say, is predominant in the under 12. Still work on concrete operations.
Yeah.
And even if you've got formal operations, you still use concrete operations quite a lot of the time. So our brains use the simplest mode to solve a problem. We're efficient. So,
It doesn't have to be the most
yeah,
sophisticated one.
sophisticated is just what works. So there are lots of things going on to
So
unpick.
before we talk, I'm wanting to talk about adults
Yeah,
before I go to talk about diversity.
yeah.
So adults,
Adults.
we're seeing more and more adults seeking out a diagnosis of autism,
Yeah.
and there are clinics popping up for making a diagnosis of autism in adult groups. And the assessment process is the same. I think the complexity is that it's more difficult in adults to get a proper neurodevelopmental history. But and then the other complexity is a person's objective experience is that, like you said, people tend to mask, and they tend to mask their difficulties, and as you grow up you have more choices and you set your life up to suit your needs, to suit how you are able, and I go back to that term, converse with the world, how you're able to converse with the world. So you choose friends who can respect your definition of friendship. You choose a job that can be suitable to your definition of right, wrong, rules, and interaction with peers. But that's one end of the spectrum. And then there is an end of the spectrum where we see people who are really, really struggling to meet the demands that are required of them as adults, hold down a job, pay their bills, form friendships, and even access help and support for physical health problems. Being able, on the very end of the spectrum, there are people who are, while verbal and appear able to engage socially, struggle to engage to a degree that really delays them and hinders them. And sometimes that comes to a point where there is a serious risk to them out of self-neglect or risk from others and vulnerabilities. So let's just touch on that really quickly. How do we think about that, and how do we assess?
So, like in adolescence, there's a group who've just been missed, who should have had a diagnosis earlier, but for one reason or another didn't. Um, there's a couple of things that happen in adulthood, isn't there? So, one reason why either autism wasn't apparent or has been missed is you're living typically as a young person in a family. That provides you with a pretty solid, structured environment, and most parents try to support their children and their young adults, so they structure the world for them. People don't leave home often until their 20s. So you may not have a problem with your autism because your family or the people you're living with do some of the things that or make
They
the world
scaffold
better
you.
for you. Yeah, they scaffold you. The other group of adults who present late may find a partner or a group of friends, but more typically a partner who does that scaffolding for them. So they can go through, they're either missed or the symptoms didn't cause a problem because somebody else helped the scaffolding, either family to start with or a partner. So you can get to your 40s, perhaps your family are no longer there, that would be normal, or your relationship and partners have disappeared, or you've got separated and divorced, and suddenly you're left as a mid-40-year-old adult struggling. And everybody goes, well, it's obvious you've got autism. Why wasn't it picked up? And it's because of the removal of support, as opposed to you've developed autism when you're 40. So our conceptualization of autism and the spectrum is it's a developmental disorder, i.e. it was something that's there from your earliest development. And we have a concept of impairment. So you only come to medical attention if it's causing a problem. So there may be lots of other factors that have stopped it causing a problem. And I think that's what sometimes happens in adults and even much older adults. As you said, they've structured a job or they've had a partner that's helped them manage the social diary and the social engagement for them. So it hasn't been a problem.
I think it's very also important to think about people who present with other problems. So sometimes people present with emotional dysregulation. They call them mood swings, or difficulties in maintaining relationships, or difficulties in following social rules. And sometimes, and I know that in some areas of the world, the training is just not very good for people who are specialized in adult psychiatry when it comes to neurodevelopmental problems like ADHD and ASD. So sometimes we see there is people tend to make diagnoses like borderline personality disorder or antisocial personality disorder or whatever personality disorder when you could have looked at the possibility of autism, the possibility of a neurodevelopmental disorder.
Yeah. It's
Um,
not only I mean, we're going back into the history of autism, but schizophrenia,
yeah,
for example, when autism was first sort of coalesced as a diagnosis,
yeah,
and it was thought of as a childhood form of schizophrenia.
yeah,
Kind of that was their idea in the 40s. So um, diagnosis or perhaps diagnostic labeling is very complex
yeah,
and is not fixed. And I think if you're a non-professional, there's a tendency to think of these things as objects. You have boxes, and actually they're probably better thought of as concepts, ideas. The whole point of them is they're a shorthand, it's helpful, it gives you a guide to treatment, intervention, or things not to do, rather than an identity. And I think if we get into the neurodiversity, we've got that complex between identity as a diagnostic label um, and not. And I think the other thing is the criteria have changed. So the scientific community have changed the criteria for autism. So it's gone from a relatively uncommon, less than 0.5% of the population to a 1-2% of the population.
yeah,
And that's also happened in people's lifetime. So you could be an adult now who would meet the current diagnosis of autism spectrum, and 30 years ago you wouldn't.
mm,
So there's lots of reasons why you might be an adult presenting with ASD.
mm,
Both the disorder, if we think of it as a disorder, or the neurodiversity, the impairment, your scaffolding, and the change in the diagnostic labeling.
mm,
So there may be, and I suppose the other one is certainly in England, Wales, UK, services are under resourced. There are long waits for assessments. You just may not have got into assessment.
mm. It's a very it's there's a lot of growth and development happening in the science in this bit. So, in the last few minutes we've got, let's talk about, is it a neurodiversity, Tim? What do you think? Is it, we keep talking about disorder, 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 but we make a distinction between autism and other disorders like a depressive disorder and we call them mental illnesses, which is a different box from developmental disorders. Is it a disorder or is it diversity?
So my starting point would be: is this causing an impairment?
Hmm.
Is this causing you, or certainly for children, your family, a significant problem? You know, if you are, I mean, I don't know whether some of these individuals do have autism or not. I mean, that it's reported. If you're a multi-billionaire computer scientist who's very fixated, rigid, perhaps lacks some social skills, are you truly disordered? You might be in some ways, but you've kind of compensated. Is that a diagnostic disorder? As
Hmm.
opposed to, you can't quite understand the social world, you can't hold down a job, you're very fixed. So I think we'd start with diagnosis is, does it cause an impairment? Okay. true of all things. You might, for example, depression. You might just be a bit grumpy and unhappy, but it doesn't cause you an impairment. Whereas we would draw the line when you have changed from your usual routine. You're much less happy. You know, can't get out of bed because you're feeling miserable. Like all of these things, at the extremes, it's easy. You can say yes and no. Yes, they're clearly disordered. No, they're not. And the trouble with the spectrum is, of course, we've got to encompass that. So
Yeah.
it's a slightly artificial problem because for most people it's pretty obvious. We probably don't understand enough about mental illness to differentiate it from neurodevelopmental. Okay, so we think most of these things are brain based at one level. But is that brain in terms of anatomy? Is it brain in terms of neurochemistry? Or is it brain in terms of the way you function? Things you've learned or not, if you like, cognitive or other types or emotions. So there are different kind of ways of thinking about brains. I suppose the essential difference that we now talk about in neurodiversity and neurodevelopmental disorders is we're saying that they're there from a very early age. There's something with you're born with, and we tend to say, oh, mental illness, depression, anxiety, and not. There is a problem with that, in that anxiety, for example, typically starts age 5 and 6. Depression's noticed 10 and 12. So is it all neurodiversity? Schizophrenia typically starts in adolescence, but we know that the brain develops differently at that point. So is that neurodiverse? I guess as a clinician, it's helpful to have some diagnostic labels and diagnostic constructs to help guide treatment and intervention, and guide families' search for information. But I think as a clinician, you have to, in my working lifetime, these definitions have changed.
My working lifetime is literally half yours, and they have changed in mine as well.
So the lesson from that is that they're not so clear or rigid, that they'll move. So if we think 20 years in the future, they'll have changed again. The people, the patients or clients or just normal people, will probably be the same. We might just call it differently. How do you resolve that issue? Well, the best person to resolve it is the person who's
themselves
presenting. But I wouldn't impose one solution on everybody.
Yeah.
For one person and one family, a clear diagnostic label can be really helpful.
Yeah.
For somebody else, actually, we keep it a bit vague. I suppose the other thing, and I know we've mainly talked about ASD today, is this is what we call comorbid. So there's comorbidity with other disorders, depression, anxiety, ADHD, but there's comorbidity but also there's comorbidity with strengths. So somebody can have a label and be really good at things. And I think that the medical side of things often forget the comorbidity with strength. So if you're very good at, we use computers. If you're very good at understanding structured kind of machines, that can be a real strength. That can overcompensate for lots of other things.
And I think that's where the conversation about diversity is very important. And I, to be honest, I tend to try not to split hairs in my mind between neurodiversity, autism spectrum disorders, autism spectrum conditions, which is another term that people sometimes prefer. And I think, like you said, ask the person to choose for themselves what label they're comfortable with at this stage in their life. That might change in the future. But what I try to tell people is that we're all wired differently. It's just that scientists have come together and said, well, this group of people are wired so similarly together to each other that we're going to group them under this term. And it seems that we know a little bit more about this group of people. I personally cannot say that it's a disorder. If you're living with it comfortably, then it's a diversity. If there is an impact or impairment, then I focus on that, and I wouldn't split hairs about a disorder or not. Um, because at the end of the day, the world is the way that it is, and it's not, if and I say that sometimes to my patients, in 100 years time, it might be that people whose brains are wired in a way that we call today autism are going to rule the world, because there are going to be more computers or more technology, and it's going to just evolve that way. And then people like me are going to be the atypical ones who are wired in a different way socially. So it's just that right now the world is not wired in a way that's welcoming specifically for people who are more sensory sensitive, who are more attracted to routines, who converse socially in different ways. So I think that's important to take into consideration, that it is a diversity in that sense. Um, but like you said, it's something that's not been resolved scientifically, and it comes down to the person and what they choose to do with that knowledge about themselves and understanding themselves. Um, and that's it. I think we had a lovely time. Thank you, Tim, for talking to us today. We talked about autism. We talked about how we diagnose autism, what it looks like in different age groups, including adulthood. We also talked about whether it's a neurodiversity or a disorder. And I hope it was helpful for people who are listening to us. Thank you, Tim.
Thank you.